Hello and good morning. This is Tom Merrill. Welcome to today's webinar with the Accountable Care Learning Collaborative. I am your host and have been your host in past webinars, and I'll be moderating today's webinar, The Benefits of Palliative Care in Value-Based Program. Dr. Diane Meier, who is the current director of the Center to Advance Palliative Care, or CAPC, a national organization devoted to increasing access to quality palliative care for the seriously ill and their families in the United States. We are also joined by Daniel Hoefer, who is the Chief Medical Officer for Sharp Healthcare's Outpatient Palliative Care Program, Transitions and Associate Medical Director for Sharp HospiceCare. In addition, he is a board-certified family practice physician, board-certified in palliative medicine, and is a part of Sharp Re's Steele Medical Group in San Diego. Thank you for being with us. So as we always do, we want to start out with just a couple housekeeping items. We want to minimize feedback, so please mute your line. I don't think that we'll be hearing from most anyway, but mute your line just as a precaution. If you're using both a phone and a computer, it's best to dial in first, then through your computer, and select the Connect via Audio option when the window pops up. Then you can mute your phone. So there will be several opportunities for questions. Please submit them using the Zoom question box. Actually, as a minor departure from our normal process, we're going to hold questions till the end because we just have so much great stuff to cover with Dr. Meier and Dr. Hoefer that we just want to protect that time and then dedicate the Q&A session at the end. So, but before we jump in, just a couple announcements from the ACLC. So our agenda is as follows. We have, we'll talk real quickly about some events coming up. I'm going to introduce the guest presenters beyond what I've done recently. We're going to have Diane present first, and then Dan present second, and then we'll have the Q&A as mentioned before. So just as a reminder, we have our next member meeting that we have co-located with HIMSS, the HIMSS 2017 event in Orlando, Florida, and members of the ACLC are invited to attend the second conference on the Tuesday hosted by our sister organization, Levitt Partners. So those registration links go out every Tuesday. Please let us know if for some reason you haven't gotten those. We want you to be there and we want to see you. So jumping into today's presentation, let me just introduce Diane Meier. So she is the director, as mentioned earlier, of the Center to Advance Palliative Care, or CAPC. She is also co-director of the Patty and J. Baker National Palliative Care Center, vice chair for public policy and professor of geriatrics and palliative medicine, Catherine Gaisman Professor of Medical Ethics, and was the founder and director of the Hertzberg Palliative Care Institute, 1997 through 2011 at the Icahn School of Medicine at Mount Sinai in New York City. Dr. Meier was named one of the 20 people who make healthcare better in the U.S. by Health Leaders Media in 2010 and was elected to the National Academy of Sciences in 2013. Dr. Meier served as a Health and Aging Policy Fellow in DC in 2009 to 2010, working both on the Senate's Health Committee and at the Department of Health and Human Services. She has over 200 peer-reviewed publications in the medical literature, and her most recent book, Meeting the Needs of Older Adults with Serious Illness, Challenges and Opportunities in an Age of Health Reform, was published by Humana in 2014. So just a real special opportunity for us to have one of the foremost national thought leaders on palliative care and palliative care integration with us. Diane, we're really thankful to have you with us. Let me also introduce Dr. Daniel Hoefer at this time, and then I'll turn it over to both of them. Dr. Hoefer, as mentioned, is the Chief Medical Officer for Sharp Healthcare's Outpatient Palliative Care Program. His background includes participation on the Risk Management and Utilization Review Committee for Sharp Re Steele since 1994, He has spent over 25 years working in nursing homes and with geriatric patients. He is EPIC trained and a leading visionary for the development of evidence-based medicine or evidence-based care model for late-stage advanced illness, and is a leading national and international speaker. He was a presenter at the World Congress of Geriatrics and Gerontology in Taiwan in November 2015 and has presented to the Department of Justice on several occasions. Additionally, Dr. Hoefer has co-authored research articles published in medical journals and was an advisor to California Department of Healthcare Services. In September 2016, Dr. Hoefer was the recipient of the first ever Doris A. Howell Award for Advancing Palliative Care. So and I truncated these bios, if you can believe that. These two have done so much in this realm, it was hard to not share at least those. And so we're really excited to have you both here. Dr. Meier and Dr. Hoefer, welcome to you both.
Thank you. Thank you for that kind of introduction. Can you guys hear us okay?
Loud and clear.
Okay. Can you move to the next slide, please? And the next slide. So I want to begin with a bit of a definition of palliative care. And I think this graphic is helpful. We had a graphic artist develop this for us. The image is of a patient sitting on a bridge with lots of traffic going by right behind him. And the area in red is bolstering up, adding new struts to the bridge, providing an added layer of support for a vulnerable person with serious illness. Can you, next please? So we think about it as an added layer of support aimed at maximizing quality of life. For example, assessing and treating pain and other symptoms and addressing the multiple stresses of a serious illness that both the patient and those who love them are dealing with. Palliative care is provided by an interdisciplinary team that works closely not only with the patient's treating physicians, usually plural, but also with their family and other caregivers. Next. It's appropriate at any age and any stage of a serious illness, so we provide palliative care to people with curable diseases like leukemia, people with chronic illnesses like heart disease or emphysema or dementia, or even cancer is a chronic disease most of the time these days, as well as people who have progressive disease. And palliative care should be provided at the same time as all other appropriate disease treatments. Next slide, please. This is a patient that I took care of a few years ago. I have their permission to use not only their story, but their photo. You can see that Mrs. B sews all her own clothes and typically makes a matching tie for Mr. B. This photo was taken at their 60th wedding anniversary celebration, which took place about 5 months after I initially met them. I met Mount Sinai, got a call around 6 p.m. on a Thursday evening from the ED attending saying, we have an 88-year-old man down here with dementia and severe low back pain, and we just can't figure out how to safely manage this back pain. Pain was described as quite severe, and he had been taking basically handfuls of extra strength Tylenol, enough to destroy his liver with no benefit. Next. The reason the ED attending had called us is because this was Mr. B's 4th emergency department visit for the same problem in a period of several months, 2 months. So he had been in the ED twice for pain. Once the pain led to a fall, and once he was confused and agitated, which turned out to be due to constipation, which was due to the extreme low back pain. Next slide, please. And his wife at his bedside or stretcher side in the ED was in tears because he was furious at her for calling 911. Next. Keep going. Just, yeah, one more. Stop there. So in the usual care situation, the care that's easy to get in the US health system, Mr. B, with predictable and preventable low back pain, had as his only care plan calling 911, which he duly did 4 times in a 3-month period, which led to 4 ED visits. And the 3 prior to when I met him, he was each time admitted to the hospital. On one of those occasions, somebody put a catheter in his bladder. He got a urinary tract infection. Then he got urosepsis. So he developed not only a hospital-acquired infection, but major functional decline. He became incontinent. He lost mobility. He became delirious. So it was something of a miracle that he survived those 3 hospitalizations, given the risk of being in the hospital for a patient like him. Next, then when you can go through, stop, go back 1. Thank you. Wish I could manage these myself. So when we met him in the ED, it became clear that Tylenol wasn't touching him. He couldn't take anti-inflammatory drugs like Motrin or Naproxen because he had renal insufficiency, so they were dangerous for him. And no one had ever tried him on a low-dose opioid because people were afraid that a frail, older, demented person with back pain on opioids, that it would just be dangerous. It would be too dangerous. He might stop breathing. He might fall. He might get more confused. So what was the result? The result was that the plan for managing back pain crises was 911 and the hospital. You'll see what I tried to do. Basically what I did was give him a very small dose of concentrated liquid morphine, 2.5 milligrams, which is a much smaller dose than you or I would need if we had acute pain. And I observed him, watched him in the ED, me and the medical student. And after about 45 minutes, the medicine had not touched him at all. He was still curled on his side with a knitted brow, very tense, refusing to talk to me or his wife. So we tried a second 2.5 milligram dose. So we had a total of 5 milligrams in about an hour. About 20 minutes later, he was like a different person. He was relaxed. He had turned over on the stretcher. He was holding his wife's hand. He was flirting with the nurses. He asked to be helped into the bathroom. He was able to get to the bathroom with one nurse assisting him. And not only was he not having trouble breathing and was he not more confused, he was much more alert, much more interactive, and much more functional after a 5 milligram dose of morphine. So I proved to myself that at least in the short term, this was a safe and effective medicine for him. Not only did it relieve the pain, he tolerated it very well. At that point, I sent the medical student across the street to fill a prescription for a concentrated liquid morphine, and then spent another hour with Mrs. B, making sure that she could safely and accurately dose the very low dose of concentrated liquid morphine that she was to give him, that she understood how much to give and when to give and what to do if it didn't work. And most importantly, that she understood that he needed a strong laxative every day in order to prevent the really intractable constipation that is associated with any dose of an opioid. And we sent them home in a taxi at about 10 o'clock that night with the laxative and the morphine. But I was nervous about this because here was a demented, frail patient with an elderly caregiver, and called my colleagues who run the house calls practice at Mount Sinai. It's called Visiting Doctors, and asked them if they could see him the next morning because I was nervous about sending a dementia patient home on morphine, and they did. They got in there at 9 o'clock the next morning, where they found a series of geriatric disasters waiting to happen. Loose throw rugs and loose electrical wires everywhere, no grab bars in the bathroom, no elevated toilet seat in the bathroom, no elevated chairs in the living room that would be easy for him to get up from, and very importantly, only old Chinese food in the refrigerator. As it turned out, Mrs. B could not go out grocery shopping because Mr. B could not accompany her because of his back, and got very agitated and confused and distressed if she left him alone. So she was just ordering from the local Chinese restaurant and didn't have a computer and didn't know from ordering groceries online. So they got a physical therapist and occupational therapist into the house. They put grab bars in the bathroom. They got one of those chairs that helps you stand up when you push a button. eliminated the loose throw rugs and the electrical wires, and made the house kind of fall-proof. The visiting docs ordered Meals on Wheels with the patient's permission. They contacted their daughter in California, who now orders groceries online every week that are delivered to the home. The visiting doc service has 24/7 telephone coverage, so you never end up calling 911. You call their number and a human being gets on the phone. Turned out that Mr. and Mrs. B had not been able to go to their church for over a year, again because of Mr. B's diminished mobility, and as a result had been completely cut off from their friends and community. Again, with their permission, we called the pastor, who actually had been new just at the time that the B's stopped going to church, and they had fallen through the cracks. And this church, like many others, has a friendly visitor program for shut-ins, and they immediately sent a member of the congregation and high school students on community service 3 afternoons a week to sit with Mr. B so Mrs. B could get out, could shop, could see her friends. And the church sends a car every Sunday to pick them up for services and gives them lunch and takes them home. And so you can see the interventions here were minimally medical, pain management, although Mr. B does not need his morphine more than once a month because he doesn't get back spasm that often. But when he does, there's something he can do about it. Now that there's the appropriate equipment and grab bars and an elevated toilet seat in the apartment, he is having many fewer episodes of back pain and really not needing the morphine much at all, but it's there in case. The support for Mrs. B, not only the food, but also her ability to be with her friends and get to church on Sundays, has had a huge impact on her mood and well-being. Obviously, the food insecurity was addressed both with Meals on Wheels and by involving the daughter, who the couple had not wanted to worry, so they never told her what was going on. Next. And Mr. B has not once been back to the ED or the hospital. This is now 3 years ago. He's now 91. Could he fall at any moment and break his hip and die? He could. But let me ask you, of these two columns, which one is higher quality and lower cost? Quite obviously, the right-hand column is higher quality and lower cost. But which one is easier to get in the current health system? And I can't hear you, but I know that you're saying that the left-hand column is much easier to get than the right-hand column. Yet it's very clear that that's a very low-value approach to care. Next slide, please. So who are the people who would benefit from this kind of care? And you can see the long list of chronic diseases and conditions like frailty and dementia that we consider to be serious illnesses. Some of them are imminently terminal, like, for example, if somebody has COPD and is on a ventilator and can't come off the ventilator. But most of these are chronic diseases with which people live, often with very poor quality of life and very high functional dependency for a long time. So these people are largely not eligible for hospice because they're not predictably dying. These diseases are then associated with less and less ability to take care of oneself, less ability to manage bathing, dressing, toileting, feeding, and the associated enormous 24/7 burden on family caregivers. And when family caregivers don't have access to help at 3 in the morning or even 6 o'clock at night, when they call their doctor's office, after hours, they get a tape that says, if this is a medical emergency, hang up now and call 911. So indeed, they do call 911 because it's the way the system is designed. End up in the ED, end up in the hospital, end up in facility-based rehab settings, and have very high Medicare and Medicaid utilization, mostly because the system is not set up to meet the needs of people like Mr. and Mrs. B where they are in their own home. Next, please. Only a very small fraction of these patients who are appropriate for palliative care are in the last year of life. Focusing on prognosis misses a big opportunity for improvement. Next. So what I'm going to do is show you a graphic. I want you to think first. If I were to say to you, of the costliest 5% of patients in America, those that end up accounting for about 50% of all healthcare spending, I would ask you to guess in your own mind what fraction of that 5% are in the last 12 months of life. And when I ask that question to an audience that can speak to me, I get ranges from anywhere from 75 to 90%. People think that most of the high spending in America is occurring in people in their last 12 months of life. Next slide. Only 11% of the costliest 5% are in fact in their last 12 months of life. And I think this is important to recognize, both because there's this myth that all the, quote, waste and spending occurs in people who are dying, and that somehow we should know that and be able to not provide usual care to those people. So first of all, I would say it's only about 1 in 10 of the high cost patients are in their last year of life. And secondly, we have no idea who's in their last year of life. We get better at this when you're maybe 1 to 2 to 3 months before death, but we don't know a year before death who is going to die within the following year. So it's not really actionable prospectively. It's knowable retrospectively, but not prospectively. And so if you can't know it prospectively, how do you act on it? Next. Half of the costliest 5% have one-time high expenditures, like a complicated surgical procedure, for example, say a total knee replacement or bilateral total knee replacement, or a valve replacement, or a hospital stay for a community-acquired pneumonia. But this 50% has one-time high spending, and in the following year regresses right back down to the mean. So this is the group that's benefiting from high-cost treatments. There's no question we could do better with that group. We have a very inefficient health system, but this is not the group where the current healthcare system is largely failing to be a match to their needs. Next. It's the 40% with persistent high spending year over year who are not predictably dying, but have very high needs for the healthcare system and are not within the last year of life. It's the 40% plus the 11% that are the palliative care eligible population. And who are these people? Next. Go back one, sorry. These are the people that we found on the prior slide: functionally impaired, very high family caregiver burden and high family caregiver stress, using 911 in the absence of any other kind of support system, with any one or a range or a combination of chronic illnesses. Could be dementia, could be frailty, could be a combination of COPD, dementia, and frailty. Again, very vulnerable, very functionally impaired, poor quality of life, but not dying. Next slide, please. What we know now from an increasing body of evidence is that palliative care delivered at the same time as disease treatment not only improves quality of life and reduces symptom burden and distress, and reduces unnecessary ED, ICU, and hospital utilization in now 5 randomized controlled trials in cancer and in lung disease, COPD. Concurrent palliative care is associated with better survival. And we can argue about what the mechanism of action of that might be. If you were asking me and I was a betting person, I would say it's avoidance of the hospital, which is a very high-risk place for complex and seriously ill, vulnerable patient populations. But it's also reduced unnecessary treatment, reduced iatrogenesis, such as unnecessary chemotherapy in the last few months of life. And it's probably not good for your health to be in terrible pain, to be stressed, and to be depressed. We know that depression is an independent predictor of mortality, and there was an 80% reduction in major depression in this randomized controlled trial. Next slide, please. And here's a bunch of other studies summarizing the prevention of avoidable crisis spending associated with palliative care in the hospital setting, in the office setting, in the home-based setting, and as supported by health insurers, in this case, Aetna, on the last line. So very consistent evidence of reduced spending and consistent levels of reduction of spending. Next slide, please. The 5 key characteristics of effective palliative care, you can go ahead and proceed. First of all is targeting. If you're delivering a costly home-based service to someone who doesn't need it, if your screening tool is too sensitive and not specific enough, you will be wasting money. Next slide, please. Very important to understand what matters most to people and to modify the care plan to achieve the priorities of the patient and the family. And that's advanced healthcare planning. Ensuring proactive pain and symptom management. Again, if Mr. B had had concentrated liquid morphine in the house and Mrs. B had been taught how and when to use it, on any one of those 3 prior hospitalizations or ED visits, the subsequent 911 calls and emergency room and hospital use would have been prevented. But none of the roughly 60 physicians who took care of him on those prior hospitalizations and ED visits felt knowledgeable enough and confident enough to use opioids safely and effectively in a 88-year-old frail, demented person because they had never been trained to do so. And supporting the family, who obviously are the linchpin and the safety net for these patients. If we don't support them, we shouldn't be surprised that they call 911 for help when they are desperate. Next, please. And then 24/7 access is critical. I don't know about you, but most of my patients' crises do not occur during working hours. They occur after hours or on weekends. And if you call your doctor, and I actually did call my doctor after hours the other day, and I got that same tape telling me to hang up now if this was a medical emergency. That system very predictably results in people like Mr. and Mrs. B calling 911. The system is perfectly designed to get the results that it gets. Next slide, please. So I'll turn it over to my friend and colleague, Dan, to talk about how this actually works.
Well, thank you, Diane. And I love everything Diane says. Today, I'm going to be talking about a specific program. So this was not defined palliative medicine. Diane has it spot on that palliative medicine starts from anybody who has a chronic or severe illness that needs assistance in their symptom management and their suffering or family dynamics. It's just an additional layer. Most of what we're going to be talking about now, however, is palliative medicine in the advanced elderly following through with chronic conditions. Next slide, please. So the development of the program started from the fact that as a family physician, I would sit in my office, I would see patients that I knew I'd done everything I was supposed to for them. The specialists had done everything they were supposed to for them. But the probability of them being admitted to the hospital, and how many times did you hear Diane say that's not the safest place for these patients? And either it is the most ethical, because that means they have to suffer through some type of decompensation. But these patients would be in my office, and I'd go, well, what can I offer them? Because in the Medicare fee-for-service world, there's no Medicare Part A skilled need for these patients yet. It was very difficult to take care of these patients. So you could predict what was coming. You knew that they were more likely to be hospitalized than make it back to see you, but we had nothing to offer them. So what we did is we used our Medicare Advantage contracts to start defining the patients who are at risk of starting to use the hospital as a tool to manage their advanced illness. I call that the revolving door of hospitalization. So what that does, it's not only that we decrease hospitalizations for disease decompensation, but we decreased emergency room visits. And as Diane said, we made a program that was available 24/7. The first program we created was our heart failure program. And these patients generally were stage 3 or greater. We had COPD patients. Most of them were on home oxygen. We used dementia past 5. You may not think that's very far along, but we included the fact that if they're past 5, they have to be at risk of starting to use the hospital as a tool to manage their illness. And why do that? And the reason is because that's where you match the medical with the economic model. The ethical keep the patient from suffering with the medical and economic models. These patients do not want to suffer through an exacerbation of their disease process. And I would say to everybody listening to this, because this is a real paradigm shift in the way we practice healthcare, we have to refine and redefine the way we think about advanced illness. In 1965, when we developed Medicare, we gave people something. That was a great issue. You break something, we'll fix it. But in 2017, we should have an idea what's coming for these patients. So they should never have to experience a heart failure exacerbation, a COPD exacerbation, a delirium episode that requires hospitalization from their dementia. Because we're so proactive, we're so mindful and so aggressive in the management of these patients that this type of care where we react to their suffering is a part of something we talk about in the past tense. Next slide. So we created a proactive palliative team available 24/7, and our team consists of a nurse, a social worker, we have a physician, a spiritual care advisor. Depending, the physician supervises, I supervise all the cases. The nurse is always involved, the social worker is always involved. The families have a choice, although we encourage spiritual care services. We'll make about, on average, 4 to 6 home visits per patient. Now that was for our heart failure program. That was the initial program. We have an active phase, so they have to learn certain metrics. They need to learn about their disease. They need to learn early signs of decompensation, because the earlier we catch this, the less likely they are to go through a more advanced episode of heart failure exacerbation. And the social worker also had a number of visits. So they had to go through, the PULSE form, they had to go through the advance directive, they had to deal with family reconciliation issues so that everybody was on the same page. And I want to say something else that's very important, because we talked about the proactive medical management of these patients. The social worker in particular was involved in the proactive psychosocial management of the patient and the family. Because where does the person from out of town end up superseding all of the great care that we work on? And that's in the emergency room or in the hospital. Well, if you're sitting when the patient has capacity talking about the inevitable consequences of the natural progression of the illness, and you can tell the loving daughter who thinks she's going to do a better job managing their parent than the parent themselves, you can actually do it when the patient has capacity to say, well, thank you for your concern, but this is what I actually want. So we resolve all of those conflicts in the patient's home, not in the hospital, not on the floor, not in the ICU, but proactively, just as proactively as we manage the patient's medical issues. So of course, in the maintenance phase, you move out of the active phase. What happens after you're out of the active phase? They're never out of the program. Several things happen. They could actually get better. They would go back to case management with the medical group. About 80 to 85% of these patients will end up on hospice, but we will follow these patients both by phone and direct visits. You can never give up direct home visits, or they will default back to their previous level of care standards. But we do contact them by phone at least monthly, and then we go visit them in between that, just to make sure they're maintaining their health status. And if they have questions or concerns, we still want to see them face to face. Next slide. So the 4 pillars of the program, not surprisingly then, are comprehensive in-home patients and family education about the disease process, proactive medical management. That's something additional. So we teach them with that little bit of cough, that tiny bit of swelling, that little bit of fatigue. Don't wait to find out if that's related to your heart failure. Call us, and we'll come in and we'll take a look at you, or we'll talk to you over the phone about what we think you need to do. Now, this is in addition to all of the usual home-based treatments you would see, for example, with heart failure. Weigh yourself, watch your diet, adjust your medications. But these are the more subtle issues that happen. When do they happen? We already heard Diane say that. at 2 o'clock in the morning, on Hanukkah Eve, on Christmas Eve, all of the inconvenient times. You know what we say? Too bad, we will be there. We're not concerned. We will be there 24/7, 365 days of the year. Our goal is for you never to have an exacerbation, so you have to suffer through drowning through your own fluids from your heart failure, ever. We use evidence-based medical prognostication. Now, I completely agree with what Diane said, because you're going to lose some sensitivity and specificity if you only use one tool. So the goal is to get supportive evidence through understanding what a totally compensated low albumin means, or what a pro-BNP when patients on maximum medical therapy of 25,000 means, or a B1 creatinine of 40 and a creatinine of 2 means, because all of those have prognostic significance, as does being depressed, having frailty syndrome, having elevated BMI, having lost weight. All of these are prognostic tools that can be lined up as bell curves. They give us some guidance, but not perfect guidance, but guidance into where the patient is in the bell curve. We deal with the proactive management of the caregiver, because we're generally not just dealing with the patient in medical groups. Who else is your patient? It's the caregiver. And what does the medical evidence show? Is that when you don't provide proactive management to the caregiver, they have a statistically significant increase in mortality. They have increased psychosocial suffering. They have increased rates of cancer. They have many medical and psychosocial issues that cause them to suffer down the road. And even though today we're looking at the patient, tomorrow we'll be looking at the caregiver, and that's just as important to us as the team approach to managing these patients. And then the last thing we do is we deal with the advanced healthcare planning, which has to do with that issue of the proactive psychosocial management of the family, so that everybody is on board. And what's unique about our program in that regard is we turn patients that would have been advocates against the healthcare industry, I'm the hero in the family, I'm going to defend mom, to advocates for mom, so that we can all be on the same page, making sure that she gets what she wants. Next page. When we initiated this program for our heart failure program, these were the initial results. We had a 57% reduction in emergency room visits and a 54% reduction in admissions to the hospital. What you don't see on this slide is of the 46% of the admissions to the hospital, most of those admissions were not for heart failure exacerbations, they were for falls. And we're working on that in addition now more aggressively to make sure our patients don't fall. Although absolutely everything Diane said about picking up the carpet, making sure you have a railing in the bathroom, have an elevated seat, all those things get taken care of, good lighting, wearing proper shoes, making sure that you have your glasses, all of those things are available. As a solution, or as a consequence, of decreasing the total number of heart failure exacerbations, which in fact decreased closer to 90–95%. The bed days per thousand didn't go down by 46%, it went down by about 80%. So for those of you that are looking for an economic model to help save money in your shared savings account, in your capitated account, in that type of care, so you can improve care for your patient population, this is a great opportunity to look at grabbing these patients and moving forward. Next slide. The cost reduction, about 43%. And I can tell you we have a recent article that we published out of JAGS. This is from JCOM, Journal of Clinical Outcomes Management. But the one we did in JAGS showed a similar reduction. The cost savings is remarkable. It's about $25,000 to $30,000. $30,000, for example, for a COPD patient, or $25,000 for a congestive heart failure patient. We did original research because nobody's proven you can save money in dementia patients. We are saving about $20,000 per dementia patient. So all of these patients and families can be managed proactively. And ironically, where do all of these patients want to be? They want to be at home. They don't want the last 100 days of their life, evolving around going in and out of the hospital, so that we can show them as healthcare providers how good we are at providing healthcare. They just want to be comfortable at home, surrounded by their loved ones, their smell, their cat, their friends. We also know that the healthier the psychosocial environment, The longer these patients live, the better their recovery, and the better they do overall. Next slide. So back to you, Diane.
Okay, thanks, Dan. I just wanted to draw our listeners' attention to this blog post from a few days ago from David, which lays out a logical set of expectations and really a brilliant analysis of how CMS has been and will be rolling out increasing requirements for delivery and payment models that are based on value, not volume. And the reason I wanted to draw everyone's attention to this blog post is because the models that Dan and I have just shown you have had enormous momentum because of the increasing attention to value as opposed to volume. And it is my belief, and I think David and his co-authors believe, that if anything, the pressure to improve quality and reduce cost is going to exponentially increase in the next years. So I found this piece very helpful, and I thought everybody else would too.
Great. Thank you so much, Diane and Dan, both of you. That was excellent. We'll take a moment here to remind our participants that if you want to ask a question, just go up to that little Q&A box and you can submit them there, and we will bring them in. But I will take sort of the moderator's prerogative and ask a couple questions while you're thinking. And my first one actually is for Diane. I think this is what you're getting to right now, and that is, I've been to several of your presentations, Diane, at conferences and in other settings, and they're always just incredibly popular, and people are just nodding their heads the entire time, has been my experience. But it does seem like there are significant barriers to palliative care programs. Maybe it's financial, maybe it's otherwise, but why isn't every organization, when I see the evidence that you and Dan have presented, just clamoring to do these types of programs? What's your experience?
Well, our healthcare system, as everyone on this call knows, has to serve two masters. In order for health systems to survive financially, the overwhelming majority of their income is still fee-for-service. And so there is a lot of attention and investment in making sure the oncologists are happy, making sure the cardiologists are happy, making sure that patients in New York City go to our health system instead of the other health system, because volume equals survival financially. For our current health system. And although the writing is on the wall about that going away, it is still the case that the great majority of the dollars are coming in through a fee-for-service volume-driven model. And that is what, quite appropriately, the C-suites of our large health systems are focused on. Can they meet payroll? Can they keep their doors open to serve the community? And in order to do that, they've got to go where the money is. That said, we are now up to more than 90% of hospitals with more than 300 beds in the US report a palliative care team. So it's not novel anymore. It's kind of standard of practice in the larger hospitals in the US that serve the largest proportion of the population with serious and complex illness. The big gap is what Dan and his team are addressing. That is that most people with serious and complex illness are not hospice eligible because they are not predictably dying, and they are not hospitalized. They are in the community. They are either at home, most of them are at home, and then a proportion, especially those with cognitive impairment, are in nursing homes and assisted living facilities. And what we don't do is provide palliative care in those settings. And my expectation is that as the pressure for value increases, and Medicaid block grants are going to massively increase pressure on Medicaid to reduce hospitalization and reduce wasteful, unnecessary interventions in a way that that has never occurred before. And then similarly, my belief is that there will be a lot of pressure on patients and families to move away from Medicare fee-for-service and towards Medicare Advantage, because it is likely that the copays and deductibles for Medicare Part A and B are going to go up. And people will essentially be forced into, in larger numbers than even now, which is over 30%, into MA plans. And MA plans, as everybody knows, are managed care Medicare plans, where again, the incentive is powerfully aligned with improving quality and reducing cost for Medicare beneficiaries. And again, the incentive, and we've seen this, that many Medicare Advantage plans are investing heavily in supporting community-based palliative care, as with Dan's program and in other numerous programs across the country. Some of them are doing it by giving teams a per member per month payment to manage the high risk, high need members of their plan. Others are investing in vendors who provide home-based palliative care, such as Aspire, Landmark, Turnkey. They're, rather than building the capacity within their regions, they're buying it from vendors. Other health plans are investing in training their network providers in core palliative care knowledge and skills, because this is a place where you can do well by doing good for the highest need, highest risk population. So we're in the midst of a very disruptive transition from fee-for-service to value, and the places that are very focused on value are aggressively investing in palliative care. It's just a very diverse and slow process in different parts of the country.
Yeah. Dan, did you have a comment there? Sorry.
Yes. First of all, I agree with everything that Diane said, but I would like to add on 2 additional things to think about. Number one, there are not enough palliative providers to go around in this country. So what we see is a lot of palliative-minded provision of care, not palliative trained. So we have to be careful about quality, and the people are getting the right metrics and right understanding of what palliative trained medicine looks like. Number 2 is I also think there's something going on, and that's a cultural change among healthcare providers. Because most of the doctors I work with are sincere, that they find moral resolution that they've done everything they were supposed to by another intervention, by another hospitalization, by another pill, by another treatment. And they don't really know how to identify or have those conversations about when to move to just simply supportive care. And I'm going to say this because I love my surgeon friends, and I love Atul Gawande, but even in his book, he didn't talk about no surgery. He talked about a lesser surgery. How about if we talk about being able to evaluate patients for risk of hospital-induced conditions and quantitate that risk, such as cognitive decline, functional decline, institutionalization. Those are not traditional metrics that we look at as outcome data that we have to be looking at in the future for every single treatment that we apply to the advanced elderly.
So, and that's Atul Gawande's book, Being Mortal. So, Dan, your 2 points are we need more trained individuals, specifically trained in palliative care, and then we also need doctors better trained, basically in an ability to know when to let go and to let their patients go into less invasive type of treatment.
Yeah. I hate to say the word "let go" because it needs to be
or transition. Yes,
transition to a supportive model, right?
No. Again, that's a misunderstanding. Okay, so we're not saying that people with heart failure and COPD will give up aggressive management of their heart failure and COPD.
Right.
Not at all. We're saying they will get more appropriate management of their heart failure and COPD in their home or in their community, rather than showing up in the ED or the hospital for a crisis because of mismanaged COPD. This is not an either-or model. This is both and. And unfortunately, the great majority of our providers, even until today, have only been trained to do more things based on what diseases the patient has. And what happens when they feel that more things won't help the patient is it's very hard to stop doing more things that you even know aren't going to help them, because what it feels like to the clinician is abandonment. It feels as if I, the doctor, am abandoning my patient, when in fact I just was never trained about what the appropriate next steps are. Abandonment should never occur. But the appropriate next steps are to figure out what the patient's needs are now and to meet them. But that has not been included in medical school and residency training to the degree.
And the irony is that, we consider all of our care aggressive care. We never would say we're doing something other than the most aggressive care possible.
Exactly. It's the appropriate care that's matched to needs instead of wrong care, harmful care, not matched to needs.
Diane and Dan, it seems, some of the things, the elements that you brought up seem very reminiscent of the things that come up in the work group that I oversee, patient-centeredness, that there's very much, there's a lot of overlap between palliative care approaches and really putting patient at the center and their needs. Any comment on that?
That is the core principle of palliative medicine and palliative care, is that we don't have the answer. We get the answer by understanding who our patient and their family are as people. What matters most to them, given the reality of their illness and their social context and their financial context and their family context, and then taking our lead from them, taking our lead from our client, the patient and family, about helping them achieve what's most important to them. And I've never once, when I've asked someone, what is most important to you now? I never ask about goals. What is most important to you now? I have never had someone answer me, I want to live forever. Not once. Yet the entire healthcare system is designed as if that is the universal wish of every person in it.
And I would like to give a personal example. I recently had one of my 98-year-old patients who was developing some black toes, but she was completely asymptomatic. And in the traditional model, first of all, with the daughter that called, they didn't recognize that she had capacity, so there was some ageism there, so they didn't speak to her because she was 98. And then when you do speak to her and say, well, what's important to you? The first thing she'll say is, hell no, I don't want to go to the hospital. I just want to know what you can do for me in my home. And so we have to change the paradigm for which we evaluate these patients to give them what they want. Of course, she got transferred to the hospital, and for one day, what happened? She developed hospital-induced delirium and is now cognitively impaired, even though she's on Eliquis, so she has a blood center in her blood clot that was causing this problem is actually probably remodeling to some extent. The question, of course, is we really do better care by transferring her to the hospital, or who are we treating when we do that? So it makes it tough.
Yeah. Dan, actually, another question I have for you. Diane mentioned the slow and painful transition that the industry is going through between paying for volume versus value. Do you feel like Sharp experiences those pains currently as well, or are they finding, through new contracts, the right type of incentives to pay for all this stuff that you're doing?
Well, we are clearly farther along, but I would say it's very Machiavellian that we have buy-in by enough providers, and the middle of the road physicians are the ones that join on, eventually get on board. But there's still a lot of foot draggers that they don't want to change from their traditional metrics they've been practicing for 30 years. And how could you possibly tell me that this is a better pathway than what I've been doing? I've been around for so long. And they're used to the widget model of care. The more widgets you produce, the more you get paid. That type of a model. You can't walk in and change the social structure of a community in a week's worth of discussions. This takes years, and it's happening. And I do think that we're supportive because we've always been in a capitated environment. But even in capitated environments, people still have that moral resolution about doing things. They just want to do them more efficiently. And we're talking about changing what's considered the most aggressive pathway to something more patient-centered. And that, to many of them, is a new model of care.
Yeah. Okay, well, thank you, Dan. Diane, any last thoughts? I think we are wrapping up with just a couple minutes left.
Yeah, I would just reinforce what Dan said, that there will never be enough palliative care specialists, people who have done postgraduate specialist training, to meet the needs of the exploding older population in the United States. And unfortunately, what we really need to do is to retrain the existing mid-career workforce in stuff they never got in medical school, residency, or nursing school. Fortunately, though, there are a lot of curricular resources available, and this is another thing that a number of payers are doing, is they are requiring preferred providers or those in network to pursue training in the basic core knowledge and skills of palliative care, like communication skills, pain and symptom management skills, basically as a condition of being in network. And that's the sort of thing that will drive the widespread clinician retraining that is so urgently needed. Right now, doctors are practicing as they were trained. And what they were trained to do is more stuff, more stuff, more stuff. No matter how we change the payment incentives, if the clinician does not know how to do anything different, they're not going to change. So the training is a heavy lift, but critically important to get care that actually meets people's needs and is high value.
Yeah. Well, we are very grateful that we have both you and Dan out there making the case for palliative care and explaining the evidence so clearly. But thanks to you both for being on today, and we really appreciate your insight and perspective. For those on, we will have an audio recording of this conference call made available. It'll be included in our weekly news summary. The next webinar will be March 8th on state initiatives on accountable care, how much progress is being made with Medicaid ACOs. If you have any questions about the ACLC or follow-up questions from this webinar, please email members@accountablecarelc.org and we'll be happy to address your questions. Thanks again, Diane and Dan. We really enjoyed having you on. All right. Goodbye, everybody.